I'm Gary Noel. I'm the lead physician for the Prince George Division of Family Practice.
I'm Olive Godwin, and I'm the executive director for the Prince George Division of Practice.
Well, I'm Roger, I'm the GP in Victoria, involved in investing with this project.
We have no particular order of some did you slides, so
Oh, did it?
Sure, I'm reading. I've got a one-page document that summarizes our RCP program and how it initiated was back in March of 2011 as a division of family practice. We've implemented this residential program as a prototype within the Fraser Health Authority. The delivery model residential care occurred out of the services requirement of us, and we had 753 complex care beds, 45 assisted living beds that were excluded. The aims of our program were to include reactive care, care of the acutely ill, emergent proactive care, regular prevention care, and enhanced clinical support. Our performance measures were to see if we could have 10% reduction in polypharmacy, 10% reduction in ER visits, 10% reduction in acute care admissions, 10% reduction in falls with associated injuries, and 10% increase in early discharge from acute care by residential care physicians. The implementation of our program really was to augment services in two ways. Schedule visits to care homes, and we had a group of 12 physicians that already had shown commitment to residential care and had been actually selected out of all physicians in the community by our long-term care facilities as people that were interested, showed interest, and showed commitment to education around residential care. They're placed on a planned 2-hour visit to the residential care as they go in on a weekly basis. And they also provided 24-hour support. This enhanced physician role was not only to augment services to these long-term care facilities, but it also meant that they would try to maintain the MRP status of the family doctor in the community, at the same time as provide acute care for patients in the long-term care facilities. At all times, the long-term care facilities had access to these physicians. And so they're sort of like our hospice within the residential care, if I can use that word. It was also meant to recruit new RCP physicians in a longitudinal fashion. And I don't know if we're supposed to address our learnings at this point, or do you want to ask that? No. And part of the process that we've learned in going forward is we've had very little attrition in these physicians. In fact, we've had none that have stepped out and gone away from providing RCP care. So our patients are taken care of. But our learnings are, number one, is at the outset, we did not involve the rest of our community in involving the family doctors in our community, see if we could bring them to the table and be part of the RCP program. So as we do start having attrition, who's going to step into that place? The other learning that we had is that we asked for these measures, but we really couldn't get the data around these evaluations that we needed so that we could improve on ourselves. And we really need to, going forward, have the data so that we can evaluate ourselves, just so that we can improve on the care of our patients. We need to bring all our physicians together with our community stakeholders, our long-term care facility people, sit down at the table, have a conversation, and see how we can best take care of our patients in a timely fashion at all times, and really going forward, coming back and saying, hey, we were successful in succession, having young doctors come in, because we have not gained young doctors into the long-term care, and going forward, sustain the system that we set out to do. We're going to move on. We're going to actually reevaluate ourselves shortly and see if we can enhance the system that we have, or even change it completely to better for our community.
South Okanagan, I'll give you a bit of background. We have a number of communities in our division. We did the residential care program for 2 communities, Summerland and Penticton. And this arose from an awareness that Summerland had somewhat of a model of care for our residential care patients, where they were seen proactively. Care conferences were held, whereas in Penticton there was nothing really organized. The care was often cared by fax. There were some patients that had not been seen for 5 years. It was identified, arguably there were a number of inappropriate transfers to the emergency department and unnecessary admissions to hospital. So that's what sort of motivated us to try to come up with a model. We worked through our collaborative services committee. This was a real a good example of growth of our CSC, where we were able to take a project and work on it together and succeed together. So it had some good unintended consequences in relationship building. We took about 11 months to come up with the model. And the model we broke down into 3 groups. One was quality improvement, and that involved both CNE work, both physician CNE, but also in the facilities for staff. We had residential medical coordinators, and we had a QI evaluator coordinator. Some examples of projects that we have worked on for quality was the palliative care, just improving facility staff awareness and skills for palliative care. The other was care conferencing. We developed a 20-minute care conference that physicians could attend, and scheduling of those care conferences where it actually would, where physicians could attend. And then communication tools. The faxes that were being sent were not very effective or efficient. We developed an SBAR faxing sort of and telephone communication protocol as well. So that was the one prong. The second one was establishing and maintaining MRP and having the MRPs do proactive visits. And the goal was to have 2 visits every 6 months, as well as a care conference once a year where advanced care planning was done, polypharmacy review, and that was to be done in 20 minutes. And then the third prong was the urgent care of reducing transfers admissions to the emergency department, and we were able to incorporate that as part of our Doctor of the Day call and combine that call. So successes, the MRP proactive visits have increased. Penticton was, I think, in the 1 per year average. They're up to 3 every 6 months. Summerland has maintained the 3 to 4. The SBAR tool has been very well received, both by the facilities as well as physicians, and the care conferences have been going very well. The next steps, I'll let Terry tell you where we're going to be.
So we actually have 4 other communities that we need to work with. So what we're going to be doing is reviewing our current model, and it does need to change. And we might take a look at the leadership. Instead of having residential medical coordinators, we may look at whether we'll have pilot 1 or 2 kind of champions in the facility, and there's some clustered care happening there, and whether or not we can form some teams. We also feel it's really important to continue with the quality improvement part of it. So we have some challenges in terms of how, with the funding, because it is a decrease for us, are we going to be able to maintain like the MRP and the leadership quality CME that we want to do. We also need to expand to our other communities, or not expand, I should say, design models that are locally relevant for that community, for those communities. And what we'd like to do is that each of them will be designing their own model, but is there a way that we can also support a network so that each community has one member? If the sign time is up. Well, each community is having one member who can be on a working group so that we have some consistency and can look at the quality issues together, and we'd like to build that from the get-go.
Hi, Mitch once again, and from Chilliwack Division and Chilliwack Family Practice, and I will want to acknowledge the work that our lead physician, Dr. Ralph Jones, has done from the beginning with this project, and he would be doing this afternoon if he weren't at one of the doctors of these board meetings today. So the background for us was in Chilliwack, there was, when we started, there was 6 facilities. Half of them were owned and operated by the health authority, and the other half were contracted private facilities. What we found was that in most of these facilities, there would be 40 to 50 physicians looking after, say, on average, 80 to 90 beds. So it was a lot of people involved, and there was actually very little coverage on a regular basis for those patients, even by their MRP. So planning for a better system, it actually started fairly early on, and there was some disruption in the planning process, but we did get on board by January of 2012. The staff at the facilities, both the directors, the administration of care facilities, and the nursing staff were really pleased to see that something was going to happen, something was going to change, and that there would be some support for the care. So we came up, we worked with a model that had a residential care physician with dedicated time to attend to the care homes on a regular basis during the day, with a link to other family physicians. So if there was an MRP for a patient, a resident within the facility, there would be a good communication, close contact to that MRP. Clustering within the care homes, reducing the number of physicians, and I'll talk about this a bit later on too, is we went to many of the care homes had, as mentioned, 50 or 60 physicians attending them. So we started clustering a little bit later on in the program, and it went down, 2 of the homes was dropped from 45 down to 25 physicians as MRPs. So that was somewhat of a success. Initial incentives to take on residents, we provided a bit of an incentive fee to do that for patients. Once the GPSC attachment fees kind of came into play, that wasn't so necessary. And we had a small incentive to address polypharmacy, and this is not this had limited success as by many of the physicians it didn't register as a priority. So key learnings, what worked well with the service and delivery model. So one of the things is the profile of residential care was raised considerably amongst the physician community. Younger doctors actually got attracted to that kind of work. One able